Hello, friends. Welcome to my eighth iteration of paradigm shifts in intensive care. We have dealt with quite a few important paradigms. Some of them have made a difference to survival. Some of them have made a difference to the morbidity and length of intensive care stay. Some of them have actually made the life of the intensivist easy, as focus has done. One area where I think paradigms have shifted for the better and have made significant difference to the outcomes of patients is in the field of neurocritical care. Nothing emphasizes the paradigm shifts and the improvement in the standard of care and the options available for patients in intensive care than the paradigm shifts that have happened in the area of acute ischemic stroke. When in 2000 when and 2002, when I was just about beginning my career in intensive care, there was a kind of therapeutic nihilism towards approach to acute ischemic stroke, although thrombolysis was just about coming in the bigger and the well-informed units. But patients who had come beyond 3 hours were confined to the physiotherapy, nasogastric feeding, and a life confined to the bed with dependence on some others for activities of daily living. Now, that paradigm has changed significantly thanks to imaging technology, thanks to the availability of better thrombolytic agents, thanks to the more easily accessible cath labs, and professional expertise in doing intraarterial thrombolysis and thrombectomy and thrombus retrievals. These have actually increased the timelines for intervention in acute ischemic stroke. So much so today that somebody who presents even as late as 24 hours, if the imaging does suggest that there is a salvageable brain, there is evidence of reversibility, we are justified and in going ahead for a therapeutic intervention with reasonable neurological improvement. This single paradigm of providing multiple options for a patient with acute ischemic stroke has probably changed the lives of quite a few patients across the world and has been a true paradigm shift in the era of in the realm of critical care, and neurocritical care has led by example. So while we speak about this paradigm shift in the approach to stroke patients, something that has kept tandem with this is the accessibility and the relevance of neuroimaging. The number of tools that are available from an imaging perspective, especially from an MRI, in terms of an MR spectroscopy, MR flare sequencing, diffusion weighted imaging, and of course the availability of the CT angiogram, have probably contributed to a better structured and more informed decision making as far as assessment of a patient with acute ischemic stroke is concerned. It's probably not the timeline that makes a difference right now, but what has happened to the brain parenchyma, the tissue, that makes a difference as far as the diffusion weighted imaging results are concerned. So the improvement in outcomes among patients with this acute ischemic stroke, the increase in the options available, has kept pace or kept hand in hand with the availability of the technology, the expertise, and the gadgetry needed for aggressive evaluation of these patients with acute ischemic stroke. The previous concept that MRIs would delay acute ischemic stroke treatment is probably no longer valid, because we go ahead with thrombolysis on the basis of a very short sequence of diffusion weighted imaging, and then we may be able to complete the intracranial and extracranial angiogram after the thrombolytic process is gone. So, thrombolytic process is done. So, management of acute ischemic stroke has now therefore become an integral team effort between the neuroradiologist, the neurointerventionist, and the intensivist, maybe the neurointensivist as well. So these two, improvement in the availability and interpretation of imaging, as well as the number of options available for patients with acute ischemic stroke, has been a very significant paradigm that has shifted in the last 20 years that I have been involved in this dynamic specialty of intensive care. So while this has happened, interpreting these images has become an integral part of the ICU training programs. Previously, when I was training, if you make out a subdural hematoma, an extradural hematoma, a hyperdense MCS sign, or an ischemic stroke, and a subarachnoid, your neuroradiology knowledge was considered adequate for an intensivist who has undergone formal training. But now, unless you can interpret the entire gamut of a brain MRI, your training is probably not complete, and you will probably have to you will probably have to rethink about your neuro training if you are not able to acquire enough skills in interpreting neuroradiology. So this has also been a paradigm shift because intensivists are now learning or expected to learn the nuances of neuroradiology as well. Another area which has seen ups and downs, but technology has helped us to fine tune the treatment and rationalize certain over aggressive therapies and personalize probably the treatment options, is subarachnoid hemorrhage. There was a time between 2000 and 2005 when triple H therapy was the norm. Triple H therapy was favored, and probably we did some harm to the patients by giving them too much fluid and tipping them over into fluid overload coupled with a neurogenic pulmonary edema. So the outcomes probably were not as good with the triple H therapy. So while we understand that maintaining cerebral perfusion with the maintenance of blood pressure and euvolemic state are good, hypervolemia, as it is in the rest of the body, is probably not good for patients with subarachnoid hemorrhage. The availability of transcranial Doppler and the skill that is required to interpret it coming from the radiologist, from the neuroradiologist to intensive care and to neurointensivists has probably added to the clinical precision with which we can diagnose vasospasm, the quickness with which we can identify vasospasm and react to it. So this has also been a good paradigm shift for us. And because of the availability of higher imaging modalities, transcranial Doppler, and the availability of bedside EEG, about which we will speak a little later, we have been able to identify a new entity called as cortical spreading depolarization, which can explain the depressed sensorium in some of these patients with subarachnoid hemorrhage, which we were not able to do a few years ago. So acute ischemic stroke and subarachnoid hemorrhage probably have seen good paradigm shifts for the betterment of patient care in the field of neurointensive care. Meningitis also has seen some paradigm shifts, especially in terms of diagnosis. Previously, we had access only to gram stain and culture, and we were limited in what we could culture in the CSF samples. But now, with the ready availability of molecular diagnostics, a wide variety of pathogens which are known to produce meningitis and meningoencephalitis, even in immunocompetent patients, have been identified. Multiple case reports of organisms which we have only read in the textbooks have now come to the fore, and we have now in a better position to give precision medicine, precision antimicrobial therapy for patients with meningitis and meningoencephalitis, where the initial laboratory tests are equivocal or confusing, which will result in a cocktail of medications. So the availability of molecular diagnostics has probably contributed to a rational use of antimicrobial therapy, be it antiviral, antifungal, anti-helminthic, in addition to the antibiotic therapy, which is usually prescribed for patients with meningitis and meningoencephalitis. Steroids have had their say in the management of meningitis, but the paradigm shifts is going into a focused subset or cohort of patients who would benefit, but there is a rationalization in whom we use steroids in meningitis. Electroencephalogram has again been an important tool which has migrated from the outpatient departments to the bedside of the patients. And 24-hour EEGs have become standard of care for those patients with depressed sensorium who do not have an explainable cause for the altered sensorium, because we now understand that non-convulsive status epilepticus is a reasonably strong entity. It's not an uncommon entity. It can happen without a motor seizure ever for the patient, and it happens in patients with no known previous seizure disorder. So the availability of portable machines, the availability of 24-hour recording facilities has improved the ability of intensivists to diagnose non-convulsive status as well as the different patterns of epileptiform discharges. Now you have a very compact device which can project the EEG by Bluetooth to wherever you are. So that's been a paradigm shift. The EEG coming from the outpatient practice to the bedside, and from the bedside, beaming those signals live to wherever you may be across the world has been a paradigm shift which has contributed to early detection of certain major problems associated with seizure disorders in the intensive care unit. So, just as imaging modalities like MRI and CT scan and transcranial Doppler have become essential skills which every intensivist has to learn, EEG has also become an integral part of the ICU curriculum, and it is now part of essential training for all intensivists who look after sick patients in the ICU. Another modality which has become more widely used in patients with neurocritical illnesses is therapeutic plasma exchange. It's been recommended for, of course, TTP for a long time, but certain conditions like a lupus cerebritis, for example, a hemolytic uremic syndrome, for example, hepatic encephalopathy where transplant is not an option, for example, or all conditions where therapeutic plasma exchange has come to the fore, and this technique again has become an integral part of our training process in intensive care training. Multimodal monitoring, which has become compact, which can be administered with a single device, is changed the way we are looking at CNS manifestations, entropy, and all the abnormal patterns that happen in a patient with neurocritical illness. So, the availability of multimodal monitoring has probably been a good paradigm shift for patients who are in the neurointensive care unit, a paradigm shift which helps the intensivist to make a better and balanced decision making. Lot of debate has happened about hypertonic saline and mannitol. The paradigm is slowly shifting towards hypertonic saline, especially in traumatic brain injury and acute ischemic stroke. Although mannitol has its role in some cohorts of patients, the availability of hypertonic saline being an issue in this country, there is a little bit of paradigm shift towards using saline, even if it is 3% saline. And the paradigm shift has been that a lot of Indian authors are now working on 3% saline versus mannitol, so more data is expected. So we can expect more paradigms shifting in favor of 3% saline over the next few years. One of the other areas where paradigm shift has happened to the betterment of patients and in the interest of patient safety is the emergence of non-invasive methods of monitoring intracranial pressure. The gold standard still remains a ventricular drain because it has a therapeutic potential, but evidence seems to suggest that such an invasive method of measuring and targeting CPP is not associated with better neurological outcomes. But interventions may be done by non-invasive techniques like a combination of an optic nerve sheath diameter assessment and combining it with the transcranial Doppler pattern. So the availability of technology, the availability of the expertise, and the recognition of the physiological or the pathophysiological changes that accompany raised intracranial pressure have been paradigm shifts, and non-invasive methods have really made this aspect of neurointensive care more safer for patients and more easily applicable to a wider cohort of intensive care patients. Now, the other area where neurointensivists and neurocritical care uh, services have played a big role is to streamline the process of brain death certification and brain death awareness. The care of a brain dead donor has now become streamlined. The guidelines, which are published by several societies, have now more or less become uniform, and the paradigm has now shifted to a more robust and a more comprehensive support of the potential organ donor who can contribute to the improved life of up to 13 people in one go. So, neurointensive care has also not just saved the one patient with raised ICP or the one patient with a raised with a acute ischemic stroke, but by improving its awareness and spreading awareness about organ donation has improved the way organ donation program across the country has improved, and the numbers of people coming forward for organ donation has increased over the last 20 years. Neuro rehab is another area where paradigm shifts have happened, and the number of devices which are available, including robotic devices which are applicable, which are effective for patients who are quadriplegic and paraplegic, are available across the country. Trained practitioners of the field of rehabilitation medicine are now available in this country, and the acceptance among the treating intensivists and other specialists that you can't be doing everything like acute medicine, the follow up care as well as rehab has dawned on them. So, we are more ready at this point of time, more willing to accept that there are specialists in the field of rehab medicine, and we are willing to send our patients to rehab centers. So, that's been a good paradigm shift. Lastly, I would not be doing justice by talking about paradigm shifts if I don't talk about the emergence of the gut brain axis. It's a two-way axis. This paradigm has emerged in the last 3 4 years, where something that goes wrong in the brain is associated with a dysfunctional gut, and this is known from a long time. But the important aspect is the dysfunction of the brain has its origins in a dysfunctional gut, and this gut brain axis plays an important role in the overall improvement or deterioration of a patient admitted to the ICU for a wide variety of reasons, not necessarily a neurological condition. So, the emergence of this concept of the gut brain axis has been essential, and it has been a very important paradigm shift that has happened in the field of neurocritical care. So, friends, these are some of my thoughts about the paradigm shifts that have happened in neurocritical care. If you please think about it, and if you feel I have missed something, please do write to me, ping me, or WhatsApp me. Happy to acknowledge it. Thank you very much. Have a good day, and Eid Mubarak to all of you in advance. Thank you.